Chairman for kind introduction. Good afternoon, everyone. I am Wan Wook Kim from Gyeongbuk National University. I'm honored to present as speaker at ISOPES Symposium. My topic is Intraoperative parathyroid gland identification and viability assessment. Today, what I'm talking about is as follows. First, introduction to parathyroid gland and currently method to identify parathyroid gland and measure a perfusion of parathyroid gland. Lastly, radio spectral contrasting imaging using portable imager that I'm currently working on. A major key point in preserving parathyroid gland are to identify parathyroid gland precisely, preserve parathyroid gland vasculature, and finally assess parathyroid gland viability. To preserve parathyroid gland well and minimize loss of function, precise localization of parathyroid gland is the first step. So, we can minimize manipulation of parathyroid gland and reduce damage to nearby blood vessels. If vasculature of parathyroid gland is damaged, this parathyroid gland without viability should be auto-transplanted. After that, a team of Professor Lee at Kosin University reported that parathyroid gland and periparathyroid gland tissue could be seen together with a single image by adding the infrared illuminator. Parathyroid gland mapping was conducted in 3 stages. 92% of parathyroid gland could be localized in stage P1 before surgical dissection. With parathyroid gland background ratio of 4.7, parathyroid gland could be clearly distinguished from the surrounding tissues. The SRL camera is installed above the operation field. If the surgeon illuminated the parathyroid gland with LED, the parathyroid gland can be detected. Although near-infrared autophagy is very effective in localizing the parathyroid gland, but the thing is that the surgeon could not tell whether the parathyroid gland are viable or not, because the resected parathyroid gland still emit autophagy signal even though it is not viable like this. It is very important to accurately evaluate the viability of parathyroid gland, because devascularized parathyroid gland must be auto-transplanted. The purpose of this study is to determine if intraoperative near-infrared autophagy imaging could improve parathyroid gland preservation and reduce postoperative hypocalcemia. The primary outcomes was the rate of postoperative hypocalcemia. The secondary outcomes were the rate of autotransplantation and inadvertent parathyroid gland resection. 121 underwent near-infrared autophagy assisted thyroidectomy, and 120 underwent conventional thyroidectomy. The temporary postoperative hypocalcemia was 9% in near-infrared autophagy group and 21% in control group. Multivariate analysis found that the use of near-infrared autophagy reduced the risk of hypocalcemia with odds ratio of 0.35. Analysis of secondary outcomes showed that the fewer patients experienced parathyroid gland autotransplantation and the number of inadvertently resected parathyroid gland was significantly lower in near-infrared autophagy group. In conclusion, the use of near-infrared autophagy for identification of parathyroid gland may help improve postoperative hypocalcemia rate and increase the parathyroid gland preservation. Flow-based system PTI was recently developed. PTI measures near-infrared autophagy signal and provides real-time quantitative information to objectively aid parathyroid gland identification. Both devices have recently gained FDA approval. A front imaging is displayed on the monitor, and tissue with elevated near-infrared autophagy are seen as gray or pseudo-color images. In the contrast, probe system involved placing a handheld probe in contact with the tissue to capture near-infrared autophagy. It provides the surgeon with real-time auditory feedback. Display panel informs the surgeon on the near-infrared autophagy intensity and the ratio, which is translated into percentage likelihood of parathyroid gland. The advantages and disadvantages of each modality are summarized at this table. Near-infrared autofluorescence imaging can provide wide-field imaging and spatial information and other surgical guidance such as lymph node at a tumor margin. However, it has the disadvantages that it is affected by UV light, cannot give real-time quantitative information, and the interpretation is subjective. In comparison, PTI provides better real-time quantitative information and can be used with UV light on. However, it has no spatial information provided. Next, we'll move to the viability assessment of parathyroid gland. As in the picture, you can see if the parathyroid gland color is ambiguous and there is no feeding blood vessel around the parathyroid gland, it is difficult for the surgeon to decide whether to leave it or to do autotransplantation. Until now, the way to assess the viability of parathyroid gland is checking the color, swelling, and vasculature of parathyroid gland. However, these methods are subjective and inaccurate. The aim of this pilot study was to evaluate the use of intraoperative parathyroid gland angiography in predicting normal parathyroid gland function after thyroidectomy. An imaging score for ICG was established. ICG 0 means the parathyroid gland is black after injection of ICG, indicating that the gland is not vascularized. ICG 2 means the parathyroid gland is white, indicating that the gland is well vascularized. ICG 1 means the parathyroid gland is gray or heterogeneous, suggests that the gland is partially vascularized. 36 patients underwent ICG angiography during thyroidectomy. At least one well-vascularized parathyroid gland was demonstrated by ICG angiography in 30 patients. All 30 patients had PTH and calcium level in a normal range postoperatively. 2 of 6 patients in whom no vascularized parathyroid gland could be demonstrated developed transient hypoparathyroidism. None of 36 patients presented symptomatic hypocalcemia. In conclusion, PTH level on POD 1 day were normal in all patients who had at least one well-vascularized parathyroid gland demonstrated by ICG angiography, and none required treatment for hypoparathyroidism. Next study is a randomized clinical trial about parathyroid gland angiography. They evaluated parathyroid gland into deep vascularized, moderately well vascularized, and well vascularized parathyroid gland. An RCT was undertaken to determine whether parathyroid gland angiography could predict postoperative hypoparathyroidism and eliminate the need for blood tests and oral calcium supplementation. The patients who had at least one well-perfused parathyroid gland on ICG angiography were randomized. Control group received standard follow-up and supplementation with calcium and vitamin D. Intervention group had no supplementation and no blood test. Primary endpoint was hypocalcemia on postoperatively 10 to 15 days. A total of 196 patients underwent ICG angiography, of whom 146 patients at least one well-perfused parathyroid gland were randomized. Intervention group was statistically non-inferior to control group. 11 of 50 excluded patients presented with hypoparathyroidism, which was significantly different from the finding in randomized patients. In conclusion, ICG angiography reliably predicts the vascularization of parathyroid gland and eliminates the need for postoperative calcium and PTH test and supplementation with calcium in patients with at least one well-perfused parathyroid gland. As shown in the result, 4 parathyroid glands were evaluated. About 25% of patients, parathyroid gland detection rate using ICG angiography was relatively low. The following is a video clip of the patient undergoing transoral of the total thyroidectomy and central lymph node dissection. Here you can see left inferior parathyroid gland, left superior parathyroid gland, and the right inferior parathyroid gland, right superior parathyroid gland is located below. ICG was injected through IV, After about 40 seconds, inferior thyroid artery gradually begin to be enhanced. After about 1 minute, left inferior parathyroid gland begin to be enhanced. Left superior parathyroid gland is normal shape and color, and it has a blood vessel which seems to be feeding vessel. However, ICG was not enhanced. In contrast with my judgment, I barely preserved the right inferior subcapsular parathyroid gland. However, it judged as non-perfused parathyroid gland, so it was auto-transplanted. Right superior parathyroid gland was judged to be moderate perfused parathyroid gland with a small feeding vessel. Left inferior parathyroid gland was thought to be a well-perfused parathyroid gland with a similar degree of enhancement to surrounding vessel. Left superior parathyroid gland had no perfusion. This patient had no hypocalcemic symptom with a normal calcium and PTH level after surgery. The evaluation of perfusion of parathyroid gland by ICG angiography is as follows. In order to you can see it, it is partially non-perfused parathyroid gland. ICG angiography can evaluate the parathyroid perfusion more objectively than surgeon's visual assessment. It is very helpful in deciding whether to do autotransplantation or leave it inside, whether it is judged as non-perfused parathyroid gland. This table shows the advantages and disadvantages of ICG fluorescein imaging. Parathyroid gland could be identified through ICG fluorescein imaging. Evaluating the perfusion of parathyroid gland can be more accurate than the visual assessment by surgeon. By evaluating the function of parathyroid gland, it allows you to decide whether to do autotransplantation. When more than one well-vascularized parathyroid gland is preserved, the possibility of postoperative hypoparathyroidism very low, so it could reduce the need for calcium tests and supplementation after surgery. However, there are still concerns using fluorescein imaging. It is also difficult to gain real-time information due to delayed response. Because the dye is washed away before long, and it could be assessed once during surgery. Patients who had allergic to enhanced CT or iodine, it is not candidate for ICG angiography. When bleeding occurs during surgery, there is a high chance of ICG being leaked and lead to blurring visualization. And if parathyroid glands are devascularized, dye cannot reach parathyroid gland through vessel. It is not quantitative. There is no criteria for partial, or poor perfusion, and it could be ambiguous. Laser spectral contrasting imaging can compensate for these shortcomings. Some of you may have heard digital angiography for the first time. This technique has the following advantages. It is non-invasive and no contrast dye required. You can check the blood flow and tissue perfusion continuously and in real time. This technique is easy for anyone to use and even portable. Shown here is our prototype design for our handheld imager and schematic diagram of our device. An example here is shown from our wrap-out study using our device. Using mode 1, our device showed a near-infrared image of a bowel when we injected ICG and highlighted blood vessel. And we switched to mode 2 laser spectral contrast imaging. Our devices were able to show detailed vasculature and perfusion without dye in real time, which is otherwise invisible to see with the naked eye. We want to evaluate the feasibility of our non-invasive compact portable handheld imaging tool to effectively localize the parathyroid gland using near-infrared autofluorescence and assess the viability of parathyroid gland using laser spectral contrast imaging intraoperatively. Next, to assess the viability of tissue with the imager, laser spectral contrast imager was used to observe the left kidney blood flow using mode 2 after renal vein ligation. We examined the color change over time in interval of 30 seconds. Important thing to note here is that there is no visible changes of kidney detected in color display. However, in laser spectral contrast image, the kidney initially showed moderate perfusion with a second of ligation, which is indicated in orange-yellow color, but gradually became ischemic and appeared in green and light blue color after 30 and 6 seconds. Eventually, the kidney turned completely dark blue and showed no perfusion. This shows our device's ability to best assess the blood flow in detail. After confirming our device's feasibility in animal model, we move on to pilot clinical study in our Gyeongbuk National University Hospital. Here is an example of feasibility data using near-infrared autofluorescence imaging. It's hard to visualize the parathyroid gland just looking at the left visible camera image, but we can see the parathyroid gland indeed emit autofluorescence signal on the right without any injection of dye. We are also able to identify vasculatures and compare the blood flow before and after clamping. We can see high blood flow of inferior thyroid artery here, but later on, our image showed lower perfusion right after clamping. We conducted laser spectral contrast imaging under mode 2. Our image visualized the parathyroid gland indicated in red color. We could say that the parathyroid gland was well vascularized in this case. It seemed based on the clinician's assessment during the thyroidectomy, and it was confirmed again by postoperative patient calcium level. On the other hand, we are able to identify that they were indeed non-viable, as they were in dark blue through the laser spectral contrast imaging. The results agree with the clinician's assessment as well. This slide is the highlight of this presentation. I was in dilemma of trusting my experience or trusting technology. Since this parathyroid gland didn't have any color change or edema and looked like normal, so I initially judged it as a normal healthy parathyroid gland. However, there was little perfusion when we evaluated by tissue perfusion mode. Therefore, I dissected around the parathyroid gland to see if there is any feeding blood vessel, and found that the blood vessel was damaged. I concluded that the parathyroid gland is devascularized and non-viable without perfusion. Finally, the parathyroid gland was auto-transplanted. To summarize, after identifying and assessing the viability of parathyroid gland, we are able to successfully detect the autofluorescence signal with the surgical light on. For viability assessment, our image differentiated between the well and poorly perfused parathyroid gland. The several system has been developed and applied in clinical practice now. I think our technique is promising method to able to do all of this. The following are organizations that are working together. I would like to thank you, Professor Richard Cher, working at Children's Regional Hospital. Thank you for your attention.